Am I audible and is my screen visible to all of you? Right. Okay. So I hope you have enjoyed the last class, and you have revised upper limb. Today we will be starting with lower limb. Okay. This is a slightly longer topic than upper limb. So keep up with me. At any point you feel I'm going too fast or you have a question, you may ask me. So let us start. Now, the lower limb starts at the hip. Okay. The pelvis per se is made of the sacrum and the hip bone. And the hip bone has three important parts, as you know, the ilium, the ischium, and the pubis. They together make the pelvis. The lower limb starts from this area. We will be starting with this subsequently. Before we proceed to the lower limb per se, the few important bony landmarks you should know. The ilium has the iliac crest, the anterior superior and the anterior inferior iliac spines. The ischium has the ischial spine over here, which divides this large curvature into two parts, the greater sciatic notch, this one, and the lesser sciatic notch. These are very important structures. We will be learning about them soon. And the pubic tubercle over here. These are all important landmarks. Okay. Now, the hip joint, it is a ball and a socket joint. Okay. And the ball is the femoral head. The socket is the acetabulum. This joint is covered by the joint capsule, which has synovial fluid inside. Okay. A closer look at the hip joint will show. So again, this is the head. This is the acetabular cavity, the ball, and the socket. Here, the joint capsule starts over here at the labrum, the acetabular margin, okay, and covers this entire thing like this and attaches on the femur at the intertrochanteric line of femur. Okay, this is the attachment of the hip joint capsule, the labrum on the acetabulum and the intertrochanteric line of femur. All right. Now look at the femur, the anterior and the posterior surface. So at the very top, you have the head, then you have the neck, then you have the greater trochanters, you have the lesser trochanter. Do not get confused between the terms trochanter and tuberosity. Greater and lesser tuberosity is in the humerus, trochanters come in the femur. Then you have the intertrochanteric line or the IT line. This is anteriorly, and posteriorly you have the thicker IT crest. Okay, as you can see, this is a very thick ridge of bone, which is the IT crest, and here it's a line, the IT line. Coming downwards on the posterior surface, you have the linea aspera, this ridge-like area, where various muscles get attached. Then further below, you have the lateral condyles with the epicondyle, then the medial condyle with the medial epicondyle. Okay, the various parts of femur. The hip joint, we saw the joint capsule is there. Besides the joint capsule, there are three very important ligaments which support the hip joint, because hip joint is has to be such a strong joint supporting the entire weight of the body. So you have the iliofemoral ligament, you have the ischiofemoral ligament, you have the pubofemoral ligament. The three parts of the hip joint, ilium, ischium, pubis, to the femur. Simple names: iliofemoral ligament, ischiofemoral ligament, pubofemoral ligament. Of these, the iliofemoral ligament is the strongest ligament of the human body. Remember this. Is it okay so far? Okay. Now, tell me, what do you think these people are doing? Anyone? Okay. So they are clearly not dancing, if that's what you're thinking. These are the various movements at the hip joint. Okay. So this guy, this is showing hip flexion. This is hip extension. This is hip abduction, movement away from the midline. This is adduction towards the midline, internal rotation, external rotation. Okay. The movements at the hip joint. Let us see the various muscles which facilitate these movements. So start with the gluteal region, the hip region. We have some superficial muscles which are the abductors and the extenders of the thigh. What are they? They are the gluteus maximus, gluteus medius, gluteus minimus, and the tensor fascia lata. A common confusion I would like to clarify: fascia lata is the deep fascia of the thigh, the lower limb. Tensor fascia lata is a muscle. It is not a fascia. Okay. So tensor fascia lata and fascia lata are different things. This is a muscle. So the abductors of the thigh, the gluteus muscles, maximus, medius, minimus, and the tensor fascia lata. Nerve supply. So gluteus maximus, it's a huge muscle. It itself requires one individual supply of its own, which is the inferior gluteal nerve. Okay. The rest three by the superior gluteal nerve. All right. So gluteus maximus, big muscle, one full nerve it requires for its own supply. Inferior gluteal nerve. The superior gluteal nerve supplies the gluteus medius, minimus, and the tensor fascia lata. The medius and the minimus they get inserted in the greater trochanter of femur, whereas the maximus in the iliotibial tract. Okay. The deep muscles they are the lateral hip rotators. They move the hip in the external rotation. Okay, external rotation or the lateral hip rotators. They include group of smaller muscles. What are they? The quadratus femoris. Do not confuse with quadriceps femoris. That's a different thing altogether. This is the quadratus femoris, then the piriformis, then the gemellus superior and inferior, and the obturator internus. Five muscles, five deep muscles of the hip region, which lateral rotate the hip. All right. Look at this diagram. So you can see the quadratus femoris here. It's a kind of a quadrangular muscle. So it's a quadratus femoris. Then you have the piriformis, this red bulk. You have the gemellus superior, gemellus inferior, and the obturator internus. What are the nerve supplies? Very simple. Nerve to piriformis, nerve to quadratus femoris, nerve to obturator internus. So far, so good. As far as the gemelli are concerned, they do not have their own individual named nerves. Okay. If you remember this diagram, you see inferior gemellus is close to the quadratus femoris. Superior is close to the obturator internus. So they take the nerves from these muscles only. So the superior gemellus supplied by the nerve to obturator internus, inferior gemellus by the nerve to quadratus femoris. Is that clear? Everyone? Yes or no? Okay. Now, a very important point for questions is the Trendelenburg sign. What happens? When you are standing, okay, with one leg elevated. Suppose you are standing with your right leg elevated, lifted. What happens? The gluteus maximus and the gluteus medius and minimus of this side will contract to keep the pelvis steady. It will not let the pelvis sag on this side. Okay. And if this is not there, so what happens? The gravity will drag it downwards like this. That is not happening because the gluteus medius and minimus of this side is contracting to keep the pelvis steady. However, if you have lifted this leg and these muscles are weak, then as expected, this side will droop downwards. Okay. Now, the point to remember is a positive Trendelenburg sign means that the leg is drooping towards the lifted side. But this is not the damaged side. This is the normal side. This is the damaged side. Okay. So, what I mean is that in simple terms, there's a saying the sound side sags. Sound means normal. So the sound side is sagging because the other side is impaired. There is no problem on this side, but you have lifted the right leg because the left muscles are weak, so the pelvis is drooping on the right side. The sound side is sagging, the problem is on the other side. Okay. So in case of a superior gluteal nerve damage, the gluteus medius and the maximus, they get paralyzed. The pelvis becomes unsteady. So when you are asked to stand unassisted on one side, say for example the right side as in this diagram, the pelvic drop will occur on the unsupported leg because the other side is weak. Okay. Sound side sags. Is this clear to everyone? Okay. Moving on, blood supply of femoral head. Again, a very important topic. So, three main arteries supply the femoral head. The medial circumflex femoral, the lateral circumflex femoral, both of which come from the deep femoral artery. Okay. And the one branch of the obturator artery through the ligamentum teres, through the head region it comes. Okay. But in a healthy adult, the main supply is from these two arteries, from the deep femoral artery, profunda femoris artery. Okay. So you see here, these arteries, they come from, so like this, they are coming, they are forming a network in this region of the neck. Okay. They form a retinaculum, a network, and then supply the femoral head. What happens if there is a fracture in this area? So this network of vessels from the lateral and medial circumflex arteries, they get damaged. Hence, the femoral head blood supply will be drastically impaired, leading to what is known as the avascular necrosis of head of femur. Okay. The artery from the head, it's a important source of blood in the pediatric group, not so much in the adult group. Okay. And this artery, the obturator artery branch, it is more commonly impaired in during dislocations. Okay. So you will not usually hear of femoral head necrosis because of dislocations, because at that time, this the femoral circumflex arteries, their supply is not impaired. They continue to supply, which is the major supply of the femoral head. So only when the fractured neck happens, when the supply from the femoral arteries get impaired, that is when you have avascular necrosis, not so much during dislocations. Okay, very important question. Continuing with the sciatic foramina. So as I had said in the first slide, so there are two large notches, the greater sciatic notch and the lesser sciatic notch divided by the ischial spine. Okay, ischial spine. So for a notch to become a foramen, there has to be some thing which will close it completely. Okay. So it is like this. Something has to close it off. What is there to close it off? There is the sacrospinous and the sacrotuberous ligaments. These two ligaments complete the circle. Okay. And make it a notch. So you have the greater sciatic notch becomes a foramen. Greater sciatic foramen is a sciatic foramen. Okay. So the greater sciatic foramen, this is the route for structures to pass from the pelvis into the gluteal region. So all the blood supply will come from the aorta, which is in the abdomen, in the pelvis. So structures have to pass from the abdominal cavity outside through a opening, which is the greater sciatic foramen. Okay. And the lesser sciatic foramen, this is through which certain structures pass from between the gluteal region and the perineum. Okay. The greater sciatic foramen, pathway for structures from the pelvis to gluteal region, and the lesser sciatic foramen for the perineum and the gluteal region. Okay. Now, what structures pass through these foramens? So, this is the greater sciatic foramen. Here, the structure which pass. First of all, you see this large green bulk. This is the piriformis muscle. The piriformis muscle divides the greater sciatic foramen into a superior and inferior compartment containing the superior gluteal artery and nerve and the inferior gluteal artery and nerve along with the sciatic nerve. Okay. So this is the greater sciatic foramen. This is the piriformis muscle. Above the muscle, you have the superior gluteal artery and the nerve. Below, you have the inferior gluteal artery and the nerve and the sciatic nerve. Okay. Similarly, see here in the next diagram also. So you have this bulk of muscle, the piriformis. You have the superior and the gluteal nerve and artery. You have the inferior gluteal nerve and artery with the sciatic nerve. And three structures pass from the greater sciatic foramen to the lesser sciatic foramen. Meaning, three structures pass through both the foramina, which are the pudendal nerve, the internal pudendal artery, and the nerve to obturator internus. The P, I, and N pin structures pass from the GSF to the SSF, meaning they pass through both the foramina. They are the pin structures: pudendal nerve, internal pudendal artery, and the nerve to obturator internus. Is this clear to everyone? Are you following? Which part? Priti Sharma, which part do you want to be repeated? Inferior one, okay. So the inferior sciatic foramen will have few structures. These three structures are to be remembered: the pudendal nerve, the internal pudendal artery, and the nerve to obturator internus. They pass from the greater sciatic foramen to the lesser sciatic foramen. Okay. Meaning these three structures are passing through both the foramen. Is that clear? This is what is asked. They will ask you which of the following structures, all of the following pass through both the foramen except, they will give you these three and one more, or they will ask you which of the following pass through both the foramen and they will give you four structures. Did you understand? All right. I hope it's clear to everyone else. Right. Now, you might remember when we discussed the upper limb, the arm, the forearm, we had divided them into compartments for ease of understanding, to understand the various muscle groups, their functions, and the nerve supply. Same thing we will do in lower limb as well. So you see, this is a cross section taken at the level of mid thigh. Okay, this is the cross section. This is the medial side. This is the lateral side. This is anterior. This is posterior. So in thigh, in this section, we have three compartments: the anterior, the medial, and the posterior. Okay. So anterior compartment has a group of muscles known as the quadriceps femoris muscle, not to be confused with quadratus femoris. So quadriceps femoris, a group of four muscles. Okay. The vastus lateralis, the vastus intermedius, the vastus medialis, and the rectus femoris. These four muscles, along with the sartorius muscle over here. Okay. So these five muscles make up the bulk of the anterior compartment of the thigh. The four quadriceps, vastus lateralis, intermedius, medialis, the rectus femoris, and the sartorius. They make up the anterior compartment. Nerve supply is the femoral nerve. We will come to the details later on. Medial compartment, you have the adductor compartment. Okay, these are the adductor group of muscles which pull the thigh towards the body. Okay, so you have the adductor magnus, the brevis, and the longus, and the strap-like gracilis muscle. Okay, the medial compartment. And posteriorly, you have the hamstring muscles, the biceps femoris long head, the short head, the semitendinosus, and the semimembranosus. Okay, these four together are known as the hamstrings. Okay, we will discuss each of these compartments in details. So the anterior compartment. So anterior compartment, the five muscles I had told you, the rectus femoris, vastus lateralis, medialis, intermedialis, along with the vastus intermedius and the sartorius. Along with this, you find three new names over here: the psoas, the iliacus, and the pectineus. They actually are not seen at this level, so it was not mentioned here. They are more from the hip region, the pelvis region. Okay, so you see this muscle. The psoas comes from the vertebra, psoas major. These muscles. Okay, these muscles. The iliacus comes from the iliac crest. Okay, and the pectineus is here. So these are more proximal muscles, and if you take a section at this level, you find the other five muscles. Okay, so all of them come in the anterior thigh compartment. All these muscles, they are supplied by the femoral nerve. So nerve of the anterior compartment is the femoral nerve. Main action is the knee extension. So anterior compartment, remember the muscles, nerve is the femoral nerve, main action is the knee extension. Medial or adductor compartment, as I had said in that slide. So you have the adductor longus, brevis, magnus, the gracilis, and the obturator externus. Okay. The nerve of the obturator compartment or the medial compartment is the obturator nerve, and the main action is hip adduction. Here you might remember two important muscles. One is the adductor magnus. So this is one of the few muscles in the body which are supplied by two nerves. So this is a very large muscle. It extends in both the medial compartment as well as the posterior compartment. As a result, it has nerves of both the medial and the posterior compartment, meaning the obturator nerve from the medial side, sciatic nerve from the posterior side. So adductor magnus, dual innervation, obturator nerve, sciatic nerve. And gracilis, this is a strong hip adductor, which is sometimes asked in MCQs as anti-rape muscle. Okay. Coming to the posterior compartment, so we have the hamstrings, the biceps femoris, long head and short head, semitendinosus, semimembranosus, and as I said in the last slide, a part of adductor magnus. So these four are known as the hamstrings. These two names are interesting. So the names mean something. Semitendinosus. So as you see in this blue colored muscle fibers, so it's a very long tendon. So almost half the muscle is of tendon. So it's a semitendinosus. The muscle bulk is here and the tendon starts quite early. And the semi-membranosus, here you see the muscle fibers, they span over a large area like a thin membrane. So it's a thin, broad muscle, semi-membranosus. Okay. Nerve of the posterior compartment is sciatic nerve. Sciatic nerve is a composite nerve. It has both tibial nerve and common peroneal nerve components. We will read about them later on. So because it has two components, common peroneal and tibial, uh, the biceps femoris short head. This muscle is supplied by the common peroneal component of the sciatic nerve. The rest by the tibial component of the sciatic nerve. Okay. But if asked which is the nerve supply of posterior compartment, answer is sciatic nerve. If in your question you get which is the nerve supply of short head of biceps femoris, if you find both the options, sciatic and common peroneal, a better answer is common peroneal. Okay. And if you find only one of the two options, sciatic or common peroneal, you can choose either of them. Okay. And the main action is hip extension, knee flexion. Is this clear to all? Okay. So, a recapitulation, hip flexors. You have the psoas iliacus, rectus femoris, pectineus arterius, and this also. So, of which the point of this slide is the most important muscle for hip flexion is the iliacus or iliopsoas together. Okay. Hip extensors, we have the gluteus muscles, of which the gluteus maximus is the most important muscle. Then hip adductors, we have the adductor group of muscles, the medial side muscles, and abductors, we have the gluteus, medius, and minimus. Okay, mainly along with the maximus and the tensor fascia lata. Coming to the knee joint. Knee joint is a hinge joint. It's a synovial joint. Okay. I hope you know the meaning of these terms, hinge joint and ball and socket joint. So ball and socket joint is where you have a socket and a ball fitting like this, like the shoulder joint and the hip joint. Hinge joint is something like this, where you have a thing like this. Okay. So the movement is like this on a hinge, like your elbow and the knee. So look at this diagram at the of the knee joint. You have the femur, you have the tibia, you have the quadriceps femoris tendon, and the patella bone. So patella is a sesamoid bone, which means it is formed in the tendon of quadriceps femoris. Okay, and you have the patellar ligament. The knee joint has movement at two axes. The transverse axis, the movement is flexion and extension, and the longitudinal axis, the movement is lateral and medial rotation. All right. Now, so you see here, there are two joining surfaces. One is the between the tibia and the femur, one between the femur and the patella. So you have the tibiofemoral and the patellofemoral surfaces. Okay, lined by hyaline cartilage. And patella, as I said, it is a sesamoid bone in the quadriceps femoris tendon. Its main function is to provide a fulcrum at the knee joint. Okay. Now, there are various structures in the knee joint, the menisci and ligaments, which stabilize the knee joint and stabilize its movements. So as you see here, this is not a very snug fitting joint, is it? The femur, the lower end of femur, the upper end of tibia, they are both kind of flat surfaces. So the menisci are there, which are C-shaped fibrocartilaginous rings, which are present between the tibia and the femur and the tibia to deepen the articular surface of the tibia and act as shock absorbers. So instead of two flat surfaces sitting like this, there's a cushioning over here which allows the femoral distal end to sit more snugly and form a more stable joint. Okay, and also act as shock absorbers. Okay, so the menisci, two menisci, medial and lateral, fibrocartilaginous rings, C-shaped, deepen the articular surface and act as shock absorbers. Then there are a few bursa. So a bursa is a sac filled with synovial fluid, and their function anywhere in the body is to decrease the friction. Around the knee joint, we have four bursae. One is the suprapatellar bursa, as you can see here, this one. Then you have the prepatellar bursa, this one. So imagine if you have to scrub the floor, you're kneeling down on the floor. The bursa which will be in contact with the floor is the prepatellar bursa. Traditionally, housemaids who have to scrub the floor, kneeling on the floor for a long time, persistent friction, that will cause prepatellar bursitis or housemaid's knee. Okay, bursa gets inflamed, leading to bursitis, known as housemaid's knee. Prepatellar bursitis, housemaid's knee. On the other hand, when you kneel down to pray like this, so you can imagine a different part of the knee will be in contact with the floor. So at that point of time, the infrapatellar bursa comes in contact with the floor. So regular kneeling like this will lead to inflammation of the infrapatellar bursa, known as infrapatellar bursitis or clergyman's knee. And you have one more, the semi-membranosus bursa posteriorly. All right. Then what more do we have? We have various ligaments. We read about the meniscus, now the ligaments. First, the collateral ligaments. So as you can see, this is the femur, this is the tibia, this is the fibula, this is the lateral side, this is the medial side. So two ligaments on two sides, the medial collateral ligament, this one, and the lateral collateral ligament, this one, attaching from the MCL from the femoral epicondyle, medial epicondyle of femur to the medial condyle of tibia, and the lateral collateral ligament from the lateral epicondyle of femur to the fibular head. They stabilize the knee joint in the sense that they prevent excessive side to side movement. They prevent excessive lateral movement or medial movement of the knee joint. Okay. Then you have the cruciate ligaments. You can see the blue and the yellow ligaments over here, cruciate ligaments, this and this. Why are they named cruciate? Because they cross each other, cruciate. What do they do? Their ACL and PCL, anterior cruciate ligament, posterior cruciate ligament. They prevent excessive anterior or posterior movement of the tibia onto the femur. Okay, because you see the femur is attached at one end over at the hip joint. Okay, but the tibia has to attach with the femur. So excessive anterior posterior movement of the tibia from the femur is restricted by the anterior cruciate ligament and the posterior cruciate ligament. Okay, so the cruciate ligaments, as is the name, prevent the excessive anterior posterior movement of the tibia on the femur. The collateral ligaments, medial and lateral, they prevent excessive side to side movement of the tibia and the femur. Is this clear? Okay. So now that we have read about the ligaments, see what injuries can happen. Okay. So the collateral ligaments, again, this is the lateral side, medial side. The role of the collateral ligament was to support the knee from the two sides, prevent excessive sideways movement. Okay. So if there is a strong lateral force, there will be excessive stretching on the medial side, leading to tearing of the medial collateral ligament. Okay, just a minute. Sorry for that. Yeah. So how can collateral ligaments get injured? So if there's excessive force from the side, force from lateral side will lead to excessive stretching on the medial side, leading to the tear of MCL. Similarly, excessive force from the medial side will lead to stretching of this side, leading to a lateral ligament injury. Most common is MCL injury. Okay. Second is the cruciate ligament. So you understand this carefully. Imagine the mechanism of injury. So ACL, suppose this is the femur, this is the tibia. ACL will prevent ACL like this. Huh? It will prevent excessive anterior movement. Suppose there is a large force from the back of the knee. So in this case, this will get stretched, this will get torn. You will have an ACL injury. Similarly, this is the femur, this is the tibia. We have the posterior lateral ligament, posterior cruciate ligament over here, PCL. The role of this is to prevent excessive posterior movement of the tibia. Suppose you are sitting in the car, suddenly the brakes are applied, okay, and this part hits the dashboard. Therefore, there will be a very large posterior force applied on the leg, which will tear the PCL and will push the tibia posteriorly, leading to a posterior cruciate ligament injury. Anterior cruciate, if there's excessive backward force from the posterior side, leading to excessive anterior movement of the tibia. Exactly opposite over here in PCL injury. So is this clear? How the injuries are happening? You can look at the diagram over here. Okay. And MCL, medial meniscus, and ACL. When these three are injured simultaneously, it's known as the unhappy triad. Okay. Next, the foot. So at the foot, there are two kinds of movements: inversion, eversion, and dorsal and plantar flexion. Let us see how they are happening. Before that, the leg. So again, leg, muscles, compartments. We have three in the leg as well. The lateral compartment, which has the peroneus longus, peroneus brevis muscles, supplied by the superficial peroneal nerve, and the artery is the peroneal artery. Very simple. Then the action is the foot eversion. Then the anterior compartment, The muscles, tibialis anterior, extensor hallucis longus, extensor digitorum longus, peroneus tertius. So this peroneus, remember, it is not in the lateral side, it is the anterior compartment. The nerve is the deep peroneal nerve, and the artery is the anteritibial artery, and the main function is the dorsiflexion and inversion of the foot. Okay. So hallucis means great toe related, hallux. Just like in upper limb, we had pollux, thumb, pollicis. In lower limb, we have hallucis. Injury to deep peroneal nerve. So the dorsiflexion will be impaired. You will have a foot drop. Then the posterior compartment. So here you have two groups of muscles, superficial and deep. The superficial muscles are gastrocnemius, soleus, plantaris. Deep muscles you have the tibialis posterior, tibialis flexor hallucis longus, flexor digitorum longus, and the popliteus. Okay. Supplied by the tibial nerve. Artery is the posterior tibial artery, and the action is the plantar flexion and inversion of foot. Okay. Is this okay? All right. Now the sciatic nerve, as I was telling you, it is a very thick nerve. Okay. It's like a ribbon. It's a very flat, broad, thick nerve in the lower limb. Root value is L4 to S3. And it is actually a combination of two nerves, common peroneal component and the tibial component. Okay. We will trace the nerve in the thigh, then you have the popliteal fossa, then the leg, and in the foot. What does it supply? How does it branch out? So in the thigh, the tibial component gives supply to all the posterior muscles. Remember, the semimembranosus, semitendinosus, biceps femoris long head, the adductor magnus. And the common peroneal gives only to the short head of biceps femoris. Okay. Then the popliteal fossa. At this point, the nerve divides into a tibial nerve and a common peroneal nerve. The tibial nerve in the leg supplies the posterior leg muscles, and in the foot gives the medial and plantar nerves, which supplies all the intrinsic foot muscles. Okay. The common peroneal nerve moves around the behind the head of fibula, divides into superficial peroneal and the deep peroneal nerve. The superficial peroneal nerve supplies the lateral leg muscles. The deep peroneal nerve supplies the anterior leg muscles. Okay, this is very important. Do not forget this. And this shows the motor supply of the lower limb, the muscles, not the sensory yet. Is this clear to everyone? Wake up, guys. Is anyone there? All right, thank you. Yes, this is the motor supply. They're all supplying the muscles, as you can see here. Now we'll talk about the sensory innervation. Okay. So in thigh, you have the lateral cutaneous nerve of thigh supplying the lateral aspect. If this nerve gets compressed for any reason, you have what is known as meralgia paresthetica. All right. Anteriorly, the femoral nerve gives the sensory supply. Medially, ocular nerve. Posteriorly, you have the posterior cutaneous nerve of thigh from the sacral plexus. In the leg, lateral aspect supplied by the sural nerve from both the tibial and common peroneal nerves. Medial, you have the saphenous nerve from the femoral nerve. So remember, sural nerve, saphenous nerve for the leg. The foot is a complex place. The dorsum of the foot supplied by the superficial peroneal nerve, except the first web space, this region, which is supplied by the deep peroneal nerve. Okay. Remember, sometimes you may get a different wording. Peroneal nerve is also known as the fibular nerve. Okay. So do not get confused if you see this word. Fibular nerve means peroneal nerve. And the sole of the foot, tibial nerve, except this lateral side of the sole, which is by the sural nerves. Okay. So thigh, anteriorly femoral nerve, medially obturator nerve, laterally lateral cutaneous nerve, posteriorly posterior cutaneous nerve. Leg, sural nerve, saphenous nerve. Foot, dorsum, completely by the superficial peroneal nerve, except the first space, which is by the deep peroneal nerve. Sole, tibial nerve, except the lateral side, which is by the sural nerve. All right. Understood? Right. Now the bones of the foot. Just like we had read about the carpal bones. She looks too pretty, try to catch her, the scaphoid and all these things. Same, we have the tarsal bones in the foot. The large calcaneus, the talus, the navicular, the three cuneiform, and the cuboid. Okay. Then you have the metatarsals, you have the phalanges. So the ankle joint formed by the tibia, fibula, and the talus. It's again a synovial joint. The function of the ankle joint is dorsal and plantar flexion of the foot. Hinge joint, ankle joint, hinge joint, dorsal and plantar flexion of the foot, bound by the tibiofibular ligaments. One important point to understand here is inversion, eversion of foot is not by the ankle joint, it's a different joint, the subtalar joint. Okay. So ankle joint, so your foot, the movements are of all the four types: dorsiflexion, plantar flexion, inversion, eversion. However, the two pairs occur at two different joints. The ankle joint is for the dorsal and plantar flexion. The inversion, eversion is by the subtalar joint. Remember this. Now here, so there are various ligaments to stabilize the ankle joint. Medial side, you have the medial ligament or the deltoid ligament, which is prone to eversion injury. Okay. So this is the deltoid ligament. You see the how it is dividing. Sorry for that. So you have the tibia over here, you have the calcaneus over here, you have the talus, you have the navicular. So you have the anterior, this slip, this one, anterior tibio-talal ligament. You have the posterior tibio-talal ligament. You have the tibio-calcaneal ligament, this one, and the tibio-navicular ligament. So all these four together is known as the deltoid ligament or the medial ligament of the ankle and is susceptible to eversion injury, which is not very common. The more common is the inversion injury, which will lead to injury of the lateral ligament. So what are the lateral ligaments we see here? Here you have the anterior, this is the fibula, this is the talus, this is the calcaneum. So you have the anterior talofibular ligament, which is most commonly injured ligament during inversion of the ankle. You have the posterior talofibular ligament, and you have the calcaneofibular ligament, is the second most common injured. So obviously, if you think of the way you walk, the twist of the ankle that you get, it is much more common to have a inversion of the ankle than a eversion. Okay. And when the ankle gets inverted, the ligaments on the lateral side get injured, of which the most commonly injured ligament is the anterior talofibular ligament, followed by the calcaneofibular ligament. Okay. And the foot arches. So you have the medial longitudinal arch, this one. You have the lateral longitudinal arch, and you have the transverse arch. So you see here on the sole, this will be the medial longitudinal arch, this is the lateral longitudinal arch, and this is the transverse arch. So each arch is supported by some muscles, some bones, some ligaments, and the plantar aponeurosis. Okay. Of these ligaments, what you must remember is very important. The plantar calcaneonavicular ligament with the spring ligament of medial arch. Okay. So ligaments supporting this movement and the injured ones, this remember, anterior talofibular. Over here, spring ligament is the plantar calcaneonavicular ligament. So there are two named ligaments in the foot. One is the deltoid ligament, one is the spring ligament. Spring ligament is a component of the arch of the foot, the plantar calcaneonavicular ligament. Now, this is solely because of questions that are asked. So this is the medial side of the foot. This is the medial malleolus. This is the flexor retinaculum. Certain structures pass behind the medial malleolus of the foot, or structures passing behind the flexor retinaculum of the foot. Just like in the hand we are studying, same in the foot. So the structures passing are the tibialis posterior, flexor digitorum longus, tibial artery, tibial nerve, and the flexor hallucis longus. From common famous mnemonic is Tom, Dick, and Nervous Harry. Okay. So these structures pass behind the medial malleolus, pass behind the flexor retinaculum. Okay. Now, just like we had the carpal tunnel syndrome, one retinaculum, one nerve getting compressed under the retinaculum. Same thing here. You have the tarsal tunnel syndrome, the flexor retinaculum and the tibial nerve getting compressed under the retinaculum, pain and paresthesia on the medial side of foot, which is aggravated on walking. Is this clear? All right. Coming to the various spaces, the femoral triangle, adductor, subsartorial triangle, then the popliteal triangle, all these things. So femoral triangle, it's a wedge-shaped area in the superomedial aspect of the anterior thigh. It is a passageway for various structures entering and leaving the anterior thigh. There are three borders, a floor and a roof. So roof is by fascia lata, the deep fascia of thigh. I remind you not to be confused with the tensor fascia lata. The floor from lateral to medial side, you have the iliacus muscle, psoas major muscle, the pectineus, and the adductor longus muscle. Okay. So there will be the iliacus over here. Then you have the psoas over here. Then you have the pectineus over here. And then you have the adductor longus, this one. They make up the floor of the femoral triangle. And the boundaries. So the superior border by the inguinal ligament, this here. Inguinal ligament forms the superior border. The lateral border by the medial border of sartorius muscle, this one. The medial border by the medial border of the adductor longus muscle. Okay. So femoral triangle, inguinal ligament, sartorius, adductor longus. floored by iliacus, psoas, pectineus, and attor longus, roofed by the fascia lata. Now the structures present in the femoral triangle, the contents. So medial to lateral, as you can see in the diagram, you have this is the triangle, the structures, lateral to medial, you have the nerve, the femoral nerve. Then you have the femoral artery, then femoral vein. Okay. So contents of femoral triangle. This is a van going outwards. Okay. VAN, van going outwards. Femoral sheath is a fascial compartment which encases the the femoral nerve, the femoral vein, the artery, and another potential space known as femoral canal. The nerve is not a component of the femoral sheath. Only the artery and the vein and a few lymphatics, they are present in the femoral sheath. So how is the femoral sheath formed? Femoral sheath is formed by downward extension of the abdominal wall fascia. Anteriorly, the fascia transversalis, posteriorly, fascia iliaca. All right. So the femoral canal is the medial compartment of the femoral sheath. Okay. If you see from above, this is the femoral sheath. This is the medial compartment, medial, intermediate, lateral. Okay. And the opening of the femoral canal is known as femoral ring. So many terms are here, do not get confused. Femoral triangle is the broad triangular area. Within the triangle, there is a sleeve of fascia containing the artery, vein, and the lymphatics, which is known as the femoral sheath. The femoral sheath, the medial most compartment, is known as femoral canal, and the opening of the canal is known as femoral ring. Is this clear? The four structures: femoral triangle, femoral sheath, femoral canal, femoral ring. So triangle is the biggest of all, of which there is a sleeve of fascia containing the femoral artery and the vein and the lymphatics. Canal is a component of the sheath, and the ring is the opening of the canal. Okay, so femoral ring. The femoral canal contains some lymphatics. Okay. Now, so femoral canal is the most medial part of the femoral sheath. Its borders are often asked. So, medially, you have the lacrimal ligament, laterally, the femoral vein, anteriorly, the inguinal ligament, posteriorly, the pectineal ligament. Okay. And the femoral ring is its opening. Is this clear to everyone so far? All right. Next, the adductor canal, also known as the Hunter's canal or subsartorial canal. It is under the sartorius muscle. So, it extends from the apex of femoral triangle to the adductor hiatus of adductor magnus. So, the adductor magnus is a very large muscle. It attaches to the femur in the distal end at various points like this. This is the femur, and the muscle is coming like this. This is the bulk of the muscle. It attaches like this, okay, by spanning in a few tendons like this. So between the tendons, there are some spaces like this, like this. So these are known as the adductor hiatus. Okay. So the femur is this. The adductor magnus muscle attaches, it comes like this. The big muscle attaches in various tendons like this. So between the tendons, there is some space, which are known as the hiatus. So adductor hiatus, adductor canal extends from the apex of the femoral triangle. So you see here in this diagram, the femoral triangle will be somewhere like this. Okay. So at the apex of the triangle, from here to a adductor hiatus, under the sartorius muscle is the subsartorial canal. It is a passageway of structures from the anterior thigh and the posterior leg. It contains the femoral artery, femoral vein, saphenous nerve, and the nerve to vastus medialis. If you look at this schematic diagram over here, this is anterior, this is posterior, this is medial, this is lateral. So it is under the sartorius. So sartorius is anteriorly, vastus medialis lies laterally, adductor longus lies posteriorly. It contains the nerve to vastus medialis, saphenous nerve, femoral artery, femoral vein. So question will be asked, all of the following are contents of the adductor canal except. So you must know all the four components. Okay, and the boundaries. Then the popliteal fossa. It is a diamond-shaped fossa in the posterior aspect of the knee. You can see the nice diamond here, the gray area. The boundaries. So superomedial, this is the medial side. This is the lateral side. Previous slide. Yes. What is it you are asking? All right. Okay. So popliteal fossa, four boundaries. Superomedial by the semimembranosus, semitendinosus. Superolateral, biceps femoris. Inferomedial, the medial head of the gastrocnemius muscle, and the inferolateral, the lateral head of gastrocnemius and the plantaris. Okay, this forms the four borders of the popliteal fossa. The floor here will be the knee joint capsule with the posterior surface of the femur and the popliteus muscle, and the roof by the skin and fascia. Okay, what does it contain? It contains the tibial and the common peroneal nerve. By this point, the sciatic nerve is divided into the two branches, the popliteal vein and the popliteal artery. So, if they ask you lateral to medial or superficial to deep, it is always NVA, nerve, vein, artery. Okay. Okay, everyone. Shall we proceed? Yes. Okay. Now we come to the arterial supply of lower limb. So as you can see, there are so many arteries. Don't get scared. We will simplify this. So we have the thigh, this part here to here is the thigh, then the leg here to here, and the foot below, and the knee in this region. That is divided into two parts. Okay. So from the thigh and the knee, start from the aorta. Aorta ends at the iliacs, so the common iliac, then the internal and the external iliacs. The internal iliac will supply the pelvic organs and the muscles in this region. We are now more focused on the external iliac artery and how it continues and its branches. So the external iliac artery continues as the femoral artery with its most important branch, the deep femoral artery. It continues at the arrector hiatus and becomes the popliteal artery. All right. This artery then continues distally. It gives off the anterotibial and the posterior tibial artery. The anterotibial continues anteriorly, and you can palpate it in your dorsum of foot as the dorsalis pedis artery. The posterior tibial artery continues, gives off the peroneal artery and the plantar arteries. Here, so this trunk is sometimes known as the tibio-peroneal trunk. Okay. Tibio-peroneal trunk, which then gives off the peroneal artery, this one, and the posterior tibial artery, this one. Okay. Or some people also say the peroneal artery is a branch of the posterior tibial artery. Okay. Remember both of them as is your question. I'll just repeat this. External iliac, femoral artery, which is deep branch, arrector hiatus, becomes the popliteal artery. Popliteal artery gives two branches, anterior tibial, posterior tibial. Anterior tibial continues as the dorsalis pedis artery. Posterior tibial gives off the peroneal artery. Or popliteal artery becomes anterior tibial and the tibio-peroneal trunk. The tibio-peroneal trunk then divides into the posterior tibial and the peroneal artery. Okay. Then the venous drainage of lower limb. Here you see this is the anterior view, this is the posterior view. So you start from the foot, the dorsal venous arch and the digital veins. They coalesce to form the great saphenous vein on the medial side. This vein which is going upwards. This is the great saphenous vein. It drains into the femoral vein over here, the saphenofemoral junction. We also have the short saphenous vein on the lateral side, okay, which also drains into the femoral vein. And you have the popliteal vein on the posterior aspect. So from the posterior side, as you can see here, the lateral and the medial plantar veins and the plantar venous arch. Here you have the dorsal venous arch. Here you have the plantar venous arch. These veins together form the popliteal vein, which drains into the femoral vein. Okay. And the thing with the venous drainage of the lower limbs is that it has two groups of veins, the superficial vein and the deep veins. Okay. So if I draw the lower limb like this, the deep veins are here and the superficial veins are here. Okay. There are certain veins which are known as perforator veins which communicate between these veins. Okay, this is superficial, this is deep, this is perforator. Okay, there are many perforators. There are a few named perforators which are important clinically in the context of varicose veins. So, mid thigh you have the Hunterian perforators. Above knee you have the Dwight perforator. In the region of just below the knee you have the Boyd perforators, and in leg you have the Cocket 1, 2, 3 perforators. Okay, how are they clinically important? So, see, lower limb is a large organ. Lot of blood comes to lower limb, and all that has to go upwards also to the heart against the gravity. So, and it is difficult for one venous system to take all that blood upwards. Okay, and there has to be some pumping also. Some pump has to be there to push the blood against the gravity from the foot upwards. The pump or the peripheral heart is the soleus muscle. Okay, so gastrocnemius, soleus, all the thick leg muscles, they contract when you walk, when you do activity, and that helps in pumping the heart from the lower limb upwards towards the heart. So when so to accommodate that huge amount of blood, the blood will come in the superficial veins. From there, it will go to the deep veins via the perforators, and the perforators will ultimately, and the deep veins will ultimately go and drain into the iliac veins in the IVC. Now, why are they important clinically? One is that these perforators are supposed to allow only one-way flow of blood. Okay, they will only allow blood to flow from the superficial system to the deep system, not the other way around. Okay. So in the condition when these perforators become incompetent, means they are allowing the blood to flow from the deep system to the superficial system. So this is the condition where the superficial veins will become engorged, dilated, tortuous, known as varicose veins. Okay, this is one of the causes of varicose veins. Okay, so from a clinical point of view, you have to identify which perforators are incompetent. Accordingly, you have to treat the patient. Is this okay? Anyone? Any questions so far regarding what we have covered? Any slide you want to be shown again? Can we continue? Okay, right. Start answering. Which of the following is not a content of the Hunter's canal? Okay. So answer is B. So you must remember the four structures present in there. Nerve to vastus medialis is a component. Which of the following do not pass through the lesser sciatic foramen? This is where you must recall the pin structures. Someone please tell me what do these three stand for? What are the pin structures? Anyone? There's no point if you don't answer. Pain structures, anyone? What does P stand for? Yes. I, N, yes. So the answer here is inferior gluteal nerve. Which of the following makes a medial boundary of the femoral ring? Medial boundary. Medial. So answer is B, obviously. Inguinal ligament is the anterior boundary. Femoral vein is the lateral boundary. Pectinis is the posterior boundary. Read the two statements. Saphenous nerve is a branch of femoral nerve and extensor digitorum brevis is present in the dorsum of foot. All right. So answer is A. Both are right statements. Okay. So whenever you find any extensor in context of foot, it is on the dorsum. Flexor is on the sole. And saphenous nerve obviously is a branch of femoral nerve. Foot drop caused by injury to yes. Straightforward question. Common peroneal nerve. Read this. A 24-year-old lady is stabbed in the buttock. Following the injury, the wound is sutured in the emergency department. 8 weeks later, she comes to the clinic. As she walks, she has a waddling gait. and difficulty with thigh abduction. On examination, she has a buttock muscle atrophy, wasting. Which nerve do you think has been injured? Right. So this is a example of superior gluteal nerve injury, where you have wasting of the gluteus medius and minimus muscles. You might also find a positive Trendelenburg sign. Popliteal fossa. Which structure forms the floor of the popliteal fossa? Yes. This is knee joint capsule. Which nerve is potentially and greatest danger of iatrogenic injury during total hip arthroplasty via the posterior approach? Think of the nerve lying in the posterior side, in the hip region. Yeah. The answer is D. Sciatic nerve lies posteriorly. Okay. Lateral cutaneous nerve is obviously lying laterally. You have been asked posterior approach. Posterior tibial artery is a branch of the popliteal artery and supplies the posterior compartment of the leg. What is the main branch of the posterior tibial artery? This is what I was talking about. Sometimes you may get questions in this school of thought, sometimes in the other one, which I told you. Yeah, so answer is peroneal artery. Read this. The femoral artery is a terminal branch of the external iliac artery behind the inguinal ligament. Which branch of femoral artery supplies the femoral head? We discussed extensively about the femoral head blood supply. Others, please contribute to the answers. Okay. So answer is profunda femoris artery. Okay. Those who have answered circumflex iliac artery. Okay. So you just remember the word circumflex. Mm. Nothing else is right in this name. So you are recalling medial and lateral circumflex femoral arteries. Not this one. Not this. Medial and lateral circumflex femoral arteries, they come from the profunda femoris artery. Okay. The entrapment syndrome could affect the deepest content in the popliteal fossa, causing calf cramps and toes tingling. Which of the following structures is the deepest content of popliteal fossa? Any more answers? We have discussed this. Popliteal fossa, NVA, superficial to deep or outside inwards, lateral to medial. So answer is wake up, please. Yeah, the answer is D. After the popliteal fossa, then the arteries divide, not in the fossa. Okay. Now, this question that come in your last examination, policeman's heel is, yeah. So plantar fasciitis. Simple. Even if you don't know what this is, all the others you see, hallux valgus, hallux rigidus, hammered toes, they all related with the toes. This happens because of long standing tight shoes, no? Plantar fasciitis. Okay, so any questions you have? Anything you want to see once again? So if there are no more questions, thank you. We will meet in our next class. Huh? Reference Policeman Hill. Yes. What is the question? Knee joint first slide. Okay. This one. Anyone else? Okay. So thank you. Bye, guys.